So I think retreatment with a different checkpoint inhibitor, a PD-1 or PD-L1, after failure of one checkpoint inhibitor is a challenging question. Retreatment with a different PD-1 blockade inhibitor, let's say, may be especially effective in those who stopped their prior treatment for reasons other than disease progression. And we have data to show that even a similar PD-1 agent, so for instance, pembrolizumab and nivolumab, may target a different epitope of PD-1. So that forms potentially the rationale for using another checkpoint inhibitor. And one thing to remember too is, the PD-1 inhibitors may also target potentially 3 different inhibitory interactions. So for instance, there's an interaction between PD-1 and PD-L1, PD-1 and PD-L2, as well as PD-L1 and B7.1. So each of these drugs, checkpoint inhibitors, can only inhibit 2 of these, inhibitory pathways. Now, on the other hand, another way of thinking about this is we also should not and should probably refrain from using multiple PD-1/PD-L1 inhibitors in sequence as a routine basis outside of clinical trials, unless or until we have sufficient data to support this practice. Because the concern there is if one has already failed one checkpoint inhibitors, I think in real life practice, there's, very little response to be gained. Switching from one checkpoint inhibitor to another. Again, unless and until we get results from prospective trials that allow prior treatment, with a PD-1 or PD-L1 test or drug, I think we need those data to validate this approach to determine whether efficacy and safety is really warranted in this, setup of sequencing. So there is a very strong rationale for using enfortumab because enfortumab is an ADC product, an antibody drug conjugate that targets Nectin-4. And Nectin-4 is actually overexpressed in most urothelial cancer tumors. And the early phase trials of EV-103 looked at combination of enfortumab and pembrolizumab, but that's in the cisplatin ineligible cohort. And even in that cohort, it was a very striking responses, in the order of like over 70%. But the basis of the FDA approval was EV-201. And this was a single arm multicenter trial that got FDA approval for enfortumab. But this is in the third line really setting because they are patients who failed prior chemotherapy and immunotherapy. And even with the heavily pretreated population of patients, they still had confirmed over objective responses in the order of like 44%. So I think this really is a good tool in our patients who failed prior immunotherapy. And again, that's the label right now. There are ongoing studies looking at it as first line in combination with pembrolizumab with or without chemotherapy. For sure, in any of these algorithms, clinical trial is going to be up there. And after all, this is how we get approval of these drugs. So if these patients did not enroll in these clinical trials, we would not be able to get to where we are right now. Now, certainly in clinical practice too, we all know very well that not all patients are going to be great candidates for clinical trials, nor they will be able to avail of it because of lack of access and for whatever reason. So I think in the lack or absence of a clinical trial, certainly we have to resort to standard of care drugs, and for which there is also not a lot, out there. And if we're saying that if a patient truly fails one checkpoint inhibitor, and the chances of response to another checkpoint inhibitor is very low, then we're really left with either erdafitinib, but that's only in the patient who tests positive for FGFR alterations, or enfortumab. So this is still an area of increased unmet need in bladder cancer.